Many patients who have dry eye disease could also have Sjögren's, but because the symptoms of Sjögren's vary, and patients may be talking about dental decay with their dentist and vaginal dryness with their GYN and eye dryness with their ophthalmologist, there's no one who's connecting the dots. So somebody has to be that person. And what I did is for my patients who did not improve in a manner I had hoped they would after implementing their therapy, I started asking additional questions like, do they have a dry mouth? Do they have a dry throat? And if the answer was yes, then I went ahead and ordered a test called the Sjögren test with 3 novel biomarkers for the earlier detection of Sjögren's disease. It is commercially available, billable to insurance, and surprisingly, a very high percentage of my patients who were what I call recalcitrant dry eye patients tested positive. So the moral of the story is, if as ophthalmologists and eye care providers, our patients have dry eye disease and they're not improving as well as we had hoped, we should absolutely order the Sjögren test in order to help make the diagnoses for these patients. Well, Hawaii and I was a long time ago, and it was many meetings ago. It's a fantastic meeting set in January on one of 3 beautiful islands in Hawaii. And what's nice is that there's ample opportunity in the afternoons to mingle with faculty and colleagues. There was a lot of emphasis, of course, on premium implants, treating patients for their astigmatism, and cataract surgery to be viewed more as refractive lens-based surgery than basic cataract surgery. At the ASCRS meeting in Washington, D.C., just in April of this year, I did a presentation on Omidria, and the number of patients was quite large, almost 600 patients, and I looked at half of them who underwent cataract surgery by me as a surgeon, the same phaco machine, the same range of implants, who did not have Omidria, and compared it to the group who had the exact same parameters but had Omidria in its irrigation solution for cataract surgery. And I had 2 co-endpoints that I was looking at. One was the use of pupil dilating devices, and the other one was surgical time. In the group in which I used Omidria, there was a statistically significant drop, about 67% decrease in pupil dilating device utilization, and about a 7% decrease in surgical time compared to the non-Omidria group. So for sure, using Omidria not only helps speed up the case, but it also decreases the cost of cases because it decreases the use of pupil dilating devices. Actually, at the ASCRS meeting, there was a lot of emphasis on dry eye disease, ocular surface disease, meibomian gland dysfunction, because without optimizing the ocular surface, it's difficult, if not impossible, to get premium outcomes with premium implants. So paying attention preoperatively will help get better data in order to plug into our formulas and deliver better post-cataract surgical outcomes. The second kind of area of interest was better diagnostics in order to not only detect dry eye, but also more accurately measure corneal topography, keratometry, and biometry, getting through thicker and more dense cataract, again, for more accurate cataract surgery outcomes. And the last kind of big area of interest is alternative drug delivery approaches for eye surgery in order to minimize the eye drop burden to patients and the cost to patients, to consider intraocular delivery of medications or possibly delivering medications through the puncta.